something that you want to present with a surprise. You know, it's very fashionable when you go to medical conferences that you listen to patients' feedback. And we do that very much when we go to cleft conferences. And we learn very much when we listen to feedback of our patients. And so with Charlie, we thought that it would be a good idea to have feedback from a little patient who's going to tell you what he liked, what he did not like, and maybe you'll have the opportunity to ask questions to our young, beautiful little patient. Can you? Oh, yeah. Can you check? Yeah, I'm sorry. So my name is Oscar, and this is my daddy. And as far as I'm concerned, my name is Oscar. I'm 11, I think. I didn't hear. When I was smaller, my jaw was pretty much retruded, what's backwards, and the upper jaw was to the front, and for that reason, I was biting on my lower lips. This is me when I was younger. So those were my teeth before. That was the first device, which was in resin. I had to wear it 1 hour during the day and for the entire night. Then this was the second contraption that they gave me. It was in silicone. It was a lot more comfortable. And I was wearing it for the entire night. Now, those are pictures of me. They are dating back to a few months. I mean, I'm older now. Those are my radiographs, my current radiographs. And this is the difference between models before and after. Now, was it difficult to wear the first device? Yes, it had to get used to. It was a bit painful for a few days. It was uncomfortable. Did I have to change my habits? Well, it took me about 1 week to get used to that. The difference in between both devices, the second one is more comfortable. Difference in favor of the silicone device. Well, Jean-Baptiste is my dad. Prepared a silicone device for me. And, well, there are different silicones. I had the first one before. It was too thick and it was uncomfortable. You need to brush it. And what's the question? I don't understand the question. Well, he needed 2 devices because he's living 1 week with his mom and 1 week with his dad. So, do you have questions? So, this feedback is also extremely valuable for me. Can I go, Dad? No, not yet. On functional devices, when children are small, the devices need to be small and they need to be very comfortable and designed. And you know that the ones by Orthoplast, they have a bumper, and the problem with the bumper is that it's uncomfortable and it's really not very comfortable at the lip level. When I have patients coming in and parents have a divorce, I usually provide 2 devices. And so I take this into consideration. So when I read in the patient's file that parents have a divorce, then the child usually goes home with 2 devices just to make for an easier management. Was it still in your mouth at the end of the night or after a while? Well, in the first month, I would find the device in the bed. But after 1 month, then it stays in my mouth for the entire duration of the night. Thank you. Well, for him, that's a very nice experience. And I'm sure that he was very happy to be a speaker at our meeting. Now, after this impromptu speaker, I'm going to talk about the subject, what was assigned to me. But before that, I'd like to thank the organizing team and also for the beautiful evening that we had yesterday. I'm an organizer for the Journée de l'Orthodontie in Paris, and so I know it's time-consuming, it's extremely expensive, and for a meeting, Journée de l'Orthodontie in Paris, we have a hard time making the budget. We know that we have a huge deficit. And yeah, I would like to thank you very much for the evening yesterday, which was superb. So I'm here to talk about unilateral mandible hypercondylia, how you can screen early signs and how you can manage. So in a nutshell, it's an excess growth of the mandibular condyle, and because of that excess growth, there's a change in the condyle volume and size. It usually starts with puberty when the other condyle stops growing. There are no reason why it starts. We assessed many avenues, potential shock or trauma, but we have no idea as to the natural evolution of the disease. You have clinical signs and radiological signs, and there's an asymmetry. So why is it important to screen early? Well, I was aware rather early that there was this condition. We usually see our patients at the age of 8 or 9, and then we follow up and we see them grow, and then we see that they have an asymmetry. And when I looked back retrospectively at the radiographs, I realized that there are early signs. And there are some conditions with which I had orthodontic treatment. And when there's orthodontic treatment, it tends to contribute in a way to asymmetry. And so the rationale is the following. If we can screen this asymmetry early on, we can avoid subsequent surgery. The gold standard is condylectomy. So what we do is remove the extra bone, because to date, nobody is able to say how much growth the condyle is going to sustain. So some patients will see their condyle grow until the age of 18 or 19, but some will have their condyle grow until the age of 30 or 40. So if you perform this condylectomy, then it's just going to stop the growth altogether. Many teams recommend to wait and see, and wait for the condyle to stop growing before they operate. And this is what you get. Look at this patient. She has a very asymmetric face with an hypercondyle positive on the right side. It had been 6 years that she's been going back and forth to a medical doctor. They would assess bone density. Bone density would demonstrate that the condition was growing and getting worse. And I suppose that had she come to my practice earlier, she wouldn't have had such a deleterious impact on her face. You see that there's an asymmetry of the entire ramus, of the entire condyle, and eventually you are going to perform maxillomandibular surgery, basal plates. Triaca is against condylectomy. He does this type of hodgepodge surgery. It's very hard to tell a patient and tell them, well, you have a condition, but we need to wait that it becomes very severe to treat you. I don't do that. As a maxillofacial surgeon, I know that a fracture of the condyle head, when performed properly, is going to remodel nicely. So I don't see the point in waiting. So when I have a patient coming in with hypercondylia, I operate as early as I can. This is another case. Adult patient, male. The computer is very slow, says the speaker, and this is very annoying. So that gentleman came in with those picture. Condylectomy, you see that the bone density assessment is positive, is currently undergoing orthodontic treatment, and eventually he will get maxillary surgery. Well, actually, I operated on him 3 weeks ago, so maxillary advancement. Now, radiographs, well, the condyles are cut. I mean, they are not visible on the radiographs because those radiographs were made in the hospital. And, well, obviously, the hospital technicians do not understand that it's very important that we see the condyles on the radiograph. However, you need to look at the size of the condyle, which is to the upper corner. Afterwards, you see that the condyle is already completely remodeled, and this is the patient right before surgery. Now, what's the purpose of my conference? First, we are going to assess the clinical radiological signs for early screening, and I'm going to discuss a decision-making tree in order to make for the best possible management. What are the early signs? To find those early signs, we performed a retrospective study in the patients of our practice. The inclusion criteria were hypercondylia, which was screened at the adult age, underlying orthopedic or orthodontic treatment, and comprehensive documentation. In our sample, we had 10 patients, 6 female, 4 male. Average age was 11. Average age was 17 when screening happened. There are a few clinical signs, some hallmarks, if you will, of hypercondylia. Usually the ramus are of 2 different sizes. The size in between both are increased. There's also an increased distance with the basal bone, and face asymmetry is frequent in 100% of the times. So obviously this is only a retrospective study with the obvious limitations. But what is typical in those young children is the chin being shifted to one side. When the chin shifts to one side, you need to check the distance between the apex and the basal plate, look at the size in between, and perform a bone density assessment. Well, what is the procedure? You perform an intravenous injection of a contrast material, and you perform a scan. It's a scan which is usually performed in cancer center. So you need to inform your patients up front that they are going to a cancer center, but the condition is not malignant. So it's not cancer, not at all. It's just that the device, the cancer scanner, are just the same. Total signs are the chin deviated to one side. This is the highly significant signs. So when you realize that the chin is being shifted to one side, it's usually a good sign. There's also usually a mandibular angle, which becomes asymmetric. So the gonial bone and the gonial angle is starting to shift. The ascending ramus usually becomes asymmetric as well. Usually the mandible becomes rounder on the side where you have the asymmetry. You saw that in the lady, the first woman, with a mandible which was very much concave. There's an asymmetry between the apex of the first molar. That's very significant as well. Sometimes you do see double tracings of the mandibular contour. The bigonial angle is also going to shift, and you're going to have a cant in the occlusal plane because you're going to have that cant and that shifting of the occlusal plane because of the condyle asymmetry. Management. early screening, of course, is of interest in order to avoid later maxillomandibular surgery. I asked the state insurance system data in order to know when, at what age, condyles are being resected. Well, I live in Normandy. This is the western part of France. And in my region, for a reason, we operate usually before the age of 20. However, in the rest of France, mostly people are operated after. So I think there's a benefit in operating earlier. The earlier, the better. If the patient comes in at the end of growth, the problem, obviously, is a wait-and-see approach, because, as I said before, there's no way to know how much the condyle is going to grow, and you may have a very severe asymmetry. The patient came in with a chin which is slightly deviated. You see that the occlusal plane is canted. You see the radiographs. In 2019, she started orthodontic treatment, and I'm under the impression that the chin is shifting more. We performed the bone assessment, and then we conducted surgery, condylectomy. Orthodontic treatment is complete. This is her presentation, still slightly asymmetric. Her face is slightly asymmetric, but doesn't change. She will remain like that, and so she will not require an extra surgery. Maybe she will need a chin wing or a chin surgery, but for the time being, she likes her profile and doesn't want surgery. Another case, the patient is class 3. Hypercondylia has two factors. Either you have a vertical impact, and in which case you will have class 2, or you may have an impact on both dimensions, vertical and horizontal. So what I'm trying to say here is that you do have hypercondylia with class 2. And usually you miss those. Don't think that class 3 equals hypercondylectomia. So we perform resection of the condyle head when she sustained orthodontic treatment. She looks like that at the moment. She will not need maxillomandibular surgery. Third case, very quickly. Undonation, deep bite, class 2. After the condylectomy, it looks like that, and the parents do not want any more treatment. So this is the decision-making tree and the underlying rationale. In a word, it's rather straightforward. You have two options. When first you perform a condylectomy, well, first you screen, you perform a first radiograph. If after 1 year the radiograph shows an increase of growth, then you propose surgery. Usually parents accept surgery. This is my experience. Surgery is the same that you have by the ear. It's exactly the same incision line that you would have in case you have a facelift. So it's exactly the same scar. Post-operatively is rather simple. It's not very comfortable. The incision line becomes completely disappears completely. You need to place elastics rather quickly after condylectomy because the ramus is going to be shortened, and for that reason you're going to have an open bite on the contralateral side. The elastics are going to help improve and settle inclusion to again avoid later subsequent surgery. Those were the data that were provided to me by the state insurance. You see that in Normandy we do 60% of condylectomy, 26% for France as a whole. So I think our strategy, whereby we screen early, really pays off. For those interested, this is my literature. This was a work in collaboration with Justine Bruxelles. She is a PhD student. She performed all the studies, and I remain available should you have any question on hypercondylia in adults, but also children. Thank you.